It's the 13th of September, 2024. This is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. A lot to get to this week. Let's get to it. A new approval by the FDA of one of the drugs that you may be using. It's the IL-23 inhibitor, guselkumab. Janssen announced that the FDA yesterday or today approved guselkumab, Tremfya, for use in adults with moderate to severely active ulcerative colitis. Now, you probably don't treat ulcerative colitis, but you do use guselkumab. You probably should know about this. It is now one of the few indications for the drug. It is approved for psoriasis, psoriatic arthritis, and now ulcerative colitis. The approval is based on phase 2 and phase 3 quasar study results showing remission in 50% of the patients at week 44 when they received a standard dose of 200 milligrams every 4 weeks. Different results with different doses, but enough to get the drug approved. So it's a regulatory announcement this week that you should be aware of. Another IL-23 inhibitor kind of made the news, at least it made a journal report, and that's risankizumab, the other IL-23 inhibitor, that's Skyrizi. And there was a report this week from the San Francisco group, UCSF. Dr. Mahadevan, Uma Mahadevan at UCSF is a leader of the Piano Registry. If you want to know a lot about immunosuppressive use, biologic use, and the safety in pregnancy, look up the Piano study with Mahadevan as the author. It's really a great study. It'll tell you a lot about what you can do and what you don't have to worry about. But this group, it's a nationwide cohort of leading GI specialists who are concerned with IBD. You know, the story with IBD is that they often have to continue the drugs to treat IBD throughout the pregnancy because if they don't, there are significant flare rates. And it was incumbent upon them to show whether or not the use of standard drugs like 6-MP or sulfasalazine, azathioprine, or the newer biologic was associated with untoward effects on either the mother or the fetus. And that is the Piano Registry. Well, in their studying many patients on many biologics, they put forth their recent brief report of 3 patients treated with risankizumab. And what they basically are saying that it looks like there's a low amount of placental transfer with risankizumab, therefore making it a fairly safe drug. And the rationale behind this is that most immunoglobulin transfer from the mother to the infant may start at week 16, but honestly, it's low level at week 16, and it increases significantly and really goes up mostly in the last trimester when 80% of immunoglobulin transfer may in fact occur, largely because of the increase in placental surface area. So the interesting thing about this drug compared to other IgG1 monoclonal antibodies is that this one has a 2 mutations that alter Fc gamma binding, and therefore maybe the reason why when they looked at the 3 infants who were born to mothers with IBD and who were taking risankizumab, they found that there was only a fraction of the maternal level in the fetal blood. And normally with other drugs like ustekinumab, fetal concentrations are 1.5 maternal concentrations. Here it was only a fraction, suggesting again that the hypothesis is probably true because of this mutation. There's probably going to be less placental transfer, especially when it matters most. They bring up this issue of placental transfer to say that very little, in fact, occurs in the first 16 weeks. And that's maybe most important because it's before 16 weeks. In fact, it's probably 8 weeks to 10 weeks that most organogenesis takes place. So the fact that so little takes place prior to 16 weeks means that this drug and maybe other drugs are less likely to contribute to congenital malformations. And that's in fact been seen with a lot of other monoclonal antibodies, and is probably going to be seen with this one. But more research is needed here, especially on this issue of placental transfer and how it's going to affect the fetus. At this point, the authors are saying that if there's a mother who's taking risankizumab, they're going to continue it during the pregnancy, pending larger studies with more patients. I think an interesting report. JAMA reported this week on the use of a placebo in treating 101 patients with chronic low back pain. So it was a randomized control trial, but it was open label. You either got open label placebo, and they told you were going to get placebo, and that patients on placebo get better, versus the patients who didn't get placebo, and they just got usual care without the injection. And guess what? At the end of 1 month, the placebo patients did a whole lot better. There's a whole lot we don't know about placebo and placebo effect, and I think it should always be kept in mind. An interesting study this week about the origins of pain, and I have some biases about this, but it's a fairly large study, 32,000 patients who underwent abdominal MRIs, and they quantified the amount of visceral fat and subcutaneous fat and looked at correlations, and this is a data set that counts all this stuff, the United Kingdom Biobank data set. It's correlations with musculoskeletal pain. And it turns out that the more fat you had, the more chronic pain you had, and this was mostly observed in women. So the real question is this adipose tissue somehow contributing to their pain, or is it a casual association? Is it just people who are in pain, who are overweight, and having more pain because they're overweight and doing less? So this is, of course, just almost like a registry or claims analysis and looking for associations. So I like to call this fishing for p-values. But I think it goes together. I think that we see plenty of patients who are in the rut of chronic pain, and obesity is often in play. And their point was that it's more so in women than it was in men. And I think that's worth keeping in mind. A JAMA network study looked at a meta-analysis of pain outcomes in patients with acute vertebral fractures, compression fractures. And in their meta-analysis of the data that's out there, they showed that short-term pain benefits were seen with nonsteroidals and calcitonin, but that preferred for long-term pain benefits, you really wanted to look at teriparatide being superior to bisphosphonates. Now, there are a lot of drugs that we could use to treat compression fractures that weren't included in this, but in the drugs that they use, those are the takeaways. And in the end, they say you probably shouldn't be using calcitonin given its toxicity and cost when you can get away with nonsteroidals, but they do sort of favor over bisphosphonates the use of teriparatide. I guess abaloparatide would probably do the same, although that wasn't studied here. A retrospective analysis of patients on hemodialysis. What can you give them? You know, hemodialysis patients have a lot of hyperuricemia and have a fairly high incidence of gout. So in their study of 181 hemodialysis patients, 97 were taking urate lowering drugs, so about half of them. And the patients that were taking urate-lowering drugs, it was 90% allopurinol, 9% febuxostat. Patients on urate-lowering therapy had significantly fewer, 58% fewer gout flares. And then overall flares in all these hemodialysis patients, 35%. But if you look at the actual numbers, it was only 23% with urate-lowering therapy and 50% without it. And that was highly significant at P, and then put in 100 zeros and the number 2, and you get your p-value if you like p-values. I'm exaggerating, but it was very significant nonetheless. Another thing I put up there, because all of you are not all of you, a few of you at least, I don't really know how many of you are perplexed, confused, and don't know what to do when the patient's got cancer and needs to be treated with a biologic. Again, we've gone over this many, many times. This is an analysis from the Houston group that looked at 2 different data sets of patients on TNF inhibitors within the first 2 years after a newly diagnosed breast cancer. That's 2,216 breast cancer patients. And they showed that taking a TNF inhibitor during or after the breast cancer diagnosis had no effect on overall survival. So again, they're on a TNF inhibitor, they go on breast cancer, or they have breast cancer, they go on TNF inhibitor. No effect on survival. And this is in line with the ACR guideline, which is if you got a solid tumor, pay no attention and treat them as if they didn't have the solid tumor, meaning use whatever you want. This includes breast cancer, colon cancer, prostate, all the solid tumors, lung, etc. Interestingly, although there was no effect on overall survival, the patients who got the TNF inhibitors did have significantly better breast cancer survival, with like 72% better versus those who took a conventional DMARD. So just for, to show you what you already know, that you believe in the data, the patients who were on glucocorticoids had overall worse survival in this analysis of 2,200 breast cancer patients. So they have breast cancer, treat them with whatever you want to treat them with. No restrictions. EULAR guidelines agree with that. ACR guidelines say that. The data overwhelmingly says that. I say it. Hopefully there's no perplexed thoughts out there in the future. Talking about breast cancer or cancer and screening, the question is, how do you screen myositis patients for cancer? Me, I don't. If they got a diagnosis of myositis, especially dermatomyositis, over age 50 and they're male, I might look a little more closely, but I'm doing with a myositis diagnosis what I should be doing anyway. Good health maintenance, making sure that they're getting all the health maintenance things they need to detect cancers early. But, it was a plenary session at ACR last year or the year before with this very aggressive regimen that was laid out that you should do things. And I didn't agree with it, but they were drawing the line in the sand, and hopefully someone's going to study it. Anyway, in this analysis of 1,432 patients who had idiopathic inflammatory myopathy, they also had CA125 blood tests and PET CT scans. And overall, actually not all of them did. 125 had CA125 within 5 years of the myositis onset. And there was a 3% false positive rate that they attributed to fibroids and endometriosis. There was a 14.3% false negative rate, meaning that the tests were negative, the patient did have cancer. In the 139 patients who had PET CT scans, 5.5% false positive rate that were due to lymphadenopathy and lung nodules, and a 29% false negative rate. And those diagnoses included mistlymphoma, breast cancer, or prostate cancer, making up most of those cases. I put this up to say, I don't know that I see any real strong indications for CA125 and PET scanning as a routine measure in someone recently diagnosed with myositis. I think you would need other signs, symptoms, and indications to make those tests cost effective. We'll talk about cost effective in a second. A cross-sectional study of patients with systemic sclerosis, they showed that patients who with PPI, a third of the patients were PPI refractory esophagitis, and 2/3 had normal esophageal findings. The patients who were PPI refractory were more likely with esophagitis to have diffuse systemic sclerosis. That's like almost 2.5 times, and they're all higher, and they're more likely to have GI dysmotility, 66% versus 8%. So I guess the point here is systemic sclerosis patients who don't respond well to PPIs for upGERD symptoms, you might want to worry about whether they have underlying GI dysmotility due to scleroderma and whether they're going to have more features of diffuse disease going forward. There was an interesting article this week from UT Southwestern on the incidence of morphia that I found interesting. The take home of this, they actually did 2 different data sets. The Trinetics, which is an EMR participating hospital data set, and IBM market scan claims data, basically showed that compared to a 1960-1980 study at the Mayo Clinic in Olmsted County, they showed that a very low incidence of morphia, and that it was going up, like 3.6% per year. And when they looked at the more recent data that they just found, it was basically 4 times that seen over what's almost 40 years ago in the Mayo Clinic. And if you extrapolated for this annual increase, you kind of met the numbers. So point number 1 is that the incidence of morphia is going up, and going up on track with what the Mayo Clinic reported in 1960 and 1983, I think it was. And the other thing is that they reported in the new data set is that there is a much clearer linkage with age, and when it's above 65, 64, it was mostly in women where morphia was going to be seen. So new insights into limited systemic sclerosis, this case being that of morphia. And lastly, there's a systemic literature review of IVIG in systemic sclerosis. Me? Never used it, never would. Might use it in a systemic sclerosis patient not responding well or myositis is a component, but that wasn't talked about here. There are 12 studies, 266 patients, and they did say there was some evidence for a beneficial effect of IVIG on skin thickening, muscle and joint pain, GI symptoms, steroid sparing, and quality of life. Hello, really? I don't have that kind of success with all the other drugs I use. But again, I'm not sure that these are well done studies. So I'm giving you a little bit of hope, but I'm going to pull the rug out from underneath you and say, take this with a grain of salt. It was not really effective in lung disease and PFTs unless you think no change is a win. The authors weren't sure, so they said, we're not sure. So am I going to use IVIG in systemic sclerosis? Based on this report, I might actually want to consider it. But honestly, I haven't used it up till now, and I'm more enthusiastic about other drugs that we've covered here in the last few months. There's a report about myositis patients and the association or the utility of anti-PM-SCL antibodies. Never ordered one, wouldn't know what to do with it. But someone else has done the work for me. Now, with these results, would I consider it? What they found in their 65 myositis patients who had PM-SCL antibodies, that ILD was a dominant feature in that subset. And by the way, it went up if they also had a myositis-specific autoantibody like JO1, etc., right? So anti-PM-SCL positive plus an MSA antibody, the incidence of ILD went up from 80% to 91%. That's kind of interesting. But the profile of patients who had PM-SCL positivity was mostly women, 90 versus 68%. More sclerodactyly, I thought this number was low, 16 versus 0%. And if you were double positive for both the PM-SCL plus the MSA antibodies, you had, as I mentioned, more ILD, but also more mortality at 21% versus 0. What I do, I'm kind of lightening up. This new era of, MDA5, NXP2, and TIF1 gamma antibodies being included in panels. I'm a little bit more liberal in using these because it does help me to know maybe what I should be worried about and maybe where this is going to go. I'd be interested in seeing what I haven't seen, and by the way, I even looked it up. I haven't seen a cost effectiveness study showing the cost effectiveness of doing these extended batteries of myositis-specific autoantibodies or now the newer set of autoantibodies. I have not seen that analysis. What I did see in looking this up is myositis is really expensive to take care of. And I did see a kind of poor report that suggested that MRIs for muscle involvement, either to localize it or to prove it, was there, but it wasn't a really good study. So you're still on your own if you're doing a lot of MRIs in patients with myositis. I'm not. I might do it if I'm having problems choosing my muscle biopsy site. But nonetheless, I think that this is an advance that should maybe tweak your thinking about where this should go. I'm going to end with methotrexate. 2 weeks ago, I said start with lupus. You should always end with methotrexate. Rheumatologists love methotrexate. This is the Journal of the American Academy of Dermatology had a consensus piece done with 27 contributors that was multidisciplinary, looking for recommendations on methotrexate use in pediatric inflammatory skin disease. Their first point of this paper, and you should look up the article on Room Now. You can read it real quick. I put in maybe half of the 46 recommendations that they have, but their first point was you don't need to have FDA approval to use methotrexate with an inflammatory skin disease. Secondly, methotrexate is commonly used in a wide variety of unapproved skin diseases like Morphia, works really well, by the way, psoriasis, for which it's approved, dermatomyositis, atopic dermatitis, lupus, sarcoidosis, alopecia areata, and also to prevent neutralizing antibodies in patients on monoclonal antibody or biologic therapy. Other recommendations, just a few here. They do recommend weight-based dosing in the pediatric population. They do recommend parenteral over oral, but allow for both, but parenteral is guaranteed, oral, who knows. They say you can stop methotrexate abruptly with no risk other than loss of control in the weeks to follow. Everyone should be on daily folic acid, 1 milligram or something like that. That you adjust or decrease or stop methotrexate for white counts less than 3,000, absolute neutrophil counts less than 1,000, and platelet counts less than 100,000. That's it for this week on the podcast. Hope you enjoyed it. We'll talk to you next week. Take good care.